Thank you for joining us today for the 5th Annual Policy Summit presented by the American Association of Kidney Patients. This year's summit is titled Patient Voice, Patient Choice, New Determinants for Kidney Policy. My name is Ed Hickey. I'm president of AAKP and serve as the chair of the Veterans Health Initiative. Professionally, I'm a veteran United States Marine Corps infantry officer. My public service career includes posts on Capitol Hill as an administrative assistant to a United States Congressman and a special assistant at the United States Department of Congress under George H.W. Bush. Following the terror attacks of September 11th, I also served as a senior advisor for Homeland Security for the Director of the United States Civil Service under President George W. Bush. Currently, I'm a practicing attorney in Los Angeles. I'm active in the armed forces legal community, working locally with the Veterans Legal Service Project of the LA County Bar Association to support the legal needs of active military personnel, reservists, and veterans. And at a personal level, I'm a fellow kidney patient. I'm also an experienced caregiver and patient advocate because of the history of kidney disease within my family. I'm pleased to introduce our session titled Critical Barriers to Care Transformation: How Payment Policies Impact Kidney Patient Consumers and Innovation Leaders. AAKP has, for over 50 years, been a champion for patient choice and innovation in kidney medicine, including therapeutics, diagnostics, and devices. That is why AAKP fights for solutions that help diagnose disease earlier, slow disease progression, and helps stop kidney failure. We are strong advocates for preemptive transplantation, greater access to kidney transplants for all patients in need, and home dialysis. AAKP defines high-quality kidney care as timely patient access to therapies that keep patients healthy and fully capable of pursuing their aspirations, such as maintaining a career in meaningful part-time or full-time work, starting a family, owning a home, and retiring securely. After decades of stalemate and little innovation, the kidney community is witnessing a golden era in kidney drug and device development. That is why, in part, AAKP declared the next 10 years is the decade of the kidney. In the past several years, the U.S. Food and Drug Administration has approved several new and safe treatments that help patients better manage kidney diseases and related conditions. AAKP anticipates more approvals in the coming years. These approvals require tremendous research, investment, patient participation in clinical trials, and advocacy. And to be clear, each FDA approval is a significant victory for kidney patients in need and the companies and researchers who have committed themselves to transforming status quo kidney care. Yet these victories are incomplete if patients cannot access the drugs and devices once the FDA has found them to be safe and approved for patient use. Patients, medical professionals in the industry are becoming increasingly frustrated by the cumbersome barriers to patient consumer access to the innovations patients have fought for decades. Some payers, including insurance companies, and at times the Centers for Medicare and Medicaid Services, or CMS, either intentionally or through a lack of understanding of the patient burden of kidney disease, erect barriers to access these FDA-approved treatments. In some cases, some payers do not support these innovations at all. AAKP believes access must be addressed now because access to future innovations will be negatively impacted if we are not successful in these initial fights. Fighting for patient access to new innovations takes courage, political sophistication, and the fortitude to win. This is why AAKP launched its Patient Voice, Patient Choice initiative in 2022. Through this interactive platform, patients and care partners can quickly identify barriers impacting care, choice, and treatment. Through AAKP, patient consumers can engage elected leaders, government agencies, and payers to raise their voice when timely access to safe, FDA-approved treatments and devices are hindered by nonsensical barriers. Simply put, AAKP is 100% committed to making certain patients receive the right treatment at the right time based on the guidance of the doctors they choose to give them care. Moving to our last speaker is Dr. Mahesh Krishnan, Group Vice President of Research and Development at DaVita. Dr. Krishnan has worked closely with AAKP over the years through our joint involvement in major collaboratives, including the Kidney Health Initiative, where he served on the KHI board with AAKP's past president, Paul Conway. He has also worked closely with past President Richard Knight to address disparate access to kidney transplantation, especially among underserved communities. Dr. Krishnan, it's a pleasure to have you with us for the Policy Summit, and I turn it over to you.
Hello, my name is Dr. Mahesh Krishnan. I'm a nephrologist, one of the DaVita Chief Medical Officers, and the Group Vice President for Research and Development. I'm really pleased today to be able to speak to you at the AAKP around innovation in kidney disease, talking a little bit about the overview there and the barriers to allowing innovative technologies to come to patients with renal disease. There's a lot going on in kidney diseases, and I'm going to talk to you about a number of these different things, but you've probably heard of a number of these items. The first is in chronic kidney disease. We use medications such as SGLT2 inhibitors, which were originally approved for diabetes, but now demonstrate great promise in terms of slowing down the progression of renal disease, as well as improving with congestive heart failure outcomes. There's an innovative new company out there called ProKidney, which is looking to create a cellular therapeutic that also can help slow down the progression of chronic kidney disease. In the ESRD side, we have some new drugs. There are hypoxic-inducing factors, which are essentially an oral version of the ESAs that we've used before to treat anemia. And there is Korsuva, which is a new medication for urine pruritus or itching. There are also new devices. For instance, there's a new dialyzer that's out that might have some benefit. There are new machines in the home and elsewhere. There are new machines on the in-center side with new technologies that improve safety and efficacy for patients that dialyze on the in-center side. And there are advances in peritoneal dialysis technology with regards to monitoring of peritonitis and other complications, which might even improve the time people can be on therapy, as well as improve the overall effectiveness of the therapy. And in transplant, there's some exciting new developments. There are new diagnostics that are out there to basically detect rejection, potentially avoiding the need for a biopsy. There are xenotransplant kidneys, which are basically kidneys that come from pigs that can actually be implanted into humans and address the shortage of organs. And there are also bioengineered organs that are developed by companies such as Miromatrix, where you can take a pig kidney, decellularize it, put in human cells, and it can be almost as effective, potentially, as a human kidney. All of these things demonstrate great promise and innovation in kidney disease. But what are the four hurdles to actually translating these scientific endeavors into a clinic near you? These four hurdles actually come from pharma, but are applicable to any technology that needs to be moved from theoretical to translational, from bench to bedside, if you will. The first hurdle is it safe and is it effective? The second hurdle is, can it be manufactured consistently? The third is there awareness and can it be accessed easily? And the last is, and perhaps most important for this conversation today, given the topic you guys have already covered, is will someone pay for it? I'm going to go over each one of these hurdles as it relates to kidney disease and describe to you what they are and how they potentially could be overcome, with a specific emphasis around how you as patients can actually be involved and be an active participant in making some of these things happen. Hurdle one, is it safe? This is paramount. Obviously, the FDA, the Food and Drug Administration in the US, does a lot of review and also mandates clinical trials. And this is their way of understanding whether a drug or a therapy or a diagnostic is safe and effective. There are barriers that actually exist, and you might have already spoken about these earlier. These include trial recruitment. How easy is it to recruit the number of patients that are required? Is it representative? Are the populations that are being studied the actual populations that will receive the drugs? And then there's actual trial conduct. How well can the trial be done? And then the analysis of the data. It is critically important to have some clarity on trial design and endpoints. There's a current debate that is going on around the low success rate around recent renal drug approvals, and to need to understand whether or not statistical separation is even possible, or if new endpoints are needed, similar to oncology. Now, what does that mean? It might mean that some of the endpoints that traditionally work for other disease states, perhaps not in end-stage renal disease, don't actually work in end-stage renal disease. And that if you're looking to see whether or not one arm performs better than another arm, it might be the case that you have to look at other outcomes other than traditional things such as mortality or morbidity. But there's a lot of debate going on as we look at the new drugs that are coming to market and how the FDA evaluates those with their trial sponsors. For you as patients, I think it is very important to be an active consumer and discuss safety issues encountered through the appropriate reporting mechanisms. If you see an issue, it's best to always come back and talk about it to make sure that people are aware. The FDA has surveillance systems that are in place to do this, which we'll cover later on. The second hurdle is, can it be manufactured appropriately? Again, the FDA, when they approve a product, doesn't just focus in on the safety and efficacy, the clinical trials we just talked about. They also focus in on manufacturing. If it's a pharmaceutical, is the plant safe? If it's a medical device, is the plant effective? Is there a surveillance system to understand what happens? The FDA also employs a post-marketing surveillance program. One of them is called MedWatch. And this is an actual active, what we call active reporting system, meaning if there are issues with drugs or other devices, that there's an active way to let the FDA know. There's also experimentation with passive reporting systems where you can use electronic medical record systems and other systems in order to identify whether there's issues with drugs or devices or other things that the FDA regulates. Again, I think that patients can and should be involved in this process, and there are many ways to actually do this. The FDA actually has patient interaction opportunities, which you might have spoken about earlier, and the Kidney Health Initiative, a joint partnership between the American Society of Nephrology and the FDA, also has a patient advisory council where you can get involved and talk about trials, trial design, interactions with how drugs and devices interact with patients, all critically important in order to identify whether or not things are being manufactured and delivered appropriately. Hurdle 3, is there awareness? And can it be easily accessed? Now, this is important. This is how do patients and providers and physicians, how does all this get educated? And this knowledge dissemination is really, really important. Conferences such as the ones we're attending right now with the AAKP, conferences such as the Kidney Health Initiative, the American Society of Nephrology, the Annual Dialysis Conference, and the Ideas Conference are all areas where you can get a really good understanding of either what's coming in the future or what is already out there. And that's really important because if you don't know about a product, it's really hard to know that you want it or don't want it. It is also important to address some of the issues of SDOH, or social determinants of health. These are non-traditional risk factors which might affect people's ability to access a therapy or utilize something. So for instance, if you're a patient that has an issue with housing insecurity and extreme homelessness, it might be difficult to access a home modality. But as we talk about it, as we think about it, there's adaptations that can be made. The same is true for aspects of financial issues or aspects of health literacy. And so this access and awareness is a topic that is broad reaching. It covers many different stakeholders, and it also has the potential to be customized to the various subsegments of patients and physicians in order to overcome some of these issues, such as social determinants of health. I think the call to action there is patients can and should be a more educated consumer. It is important to know what is possible, and so you can advocate for it and ask your providers or your physicians for these new and innovative therapies, because if you don't know about them, it's really hard to go and see if they're appropriate for you. Hurdle 4, which we're going to spend a lot of time on, is will someone pay for it? And I think this one is quite important. And I'm going to cover CKD and transplant first because those are actually less complicated, quite candidly. And then I'm going to spend some time on the specifics of how innovation comes into the end-stage renal disease payment system for dialysis, and what some of the actual acronyms are, and what some of the pros and cons are of each one of those. So for CKD, or chronic kidney disease, renal patients not yet on dialysis or not with a transplant, many of those are actually done through physician codes. So CPT codes are procedural codes that physicians can use to access new technologies, such as new labs or new devices. And then if you have Medicare Part B or Part D, there's another way that you can access new and innovative therapies for chronic kidney disease. So Medicare Part B, these are the injectable medications that you might get in an infusion center, and Medicare Part D are oral medications. I will add here that some patients may actually also be on Medicare Advantage. And these same codes generally apply, but there's a second layer of oversight with the providers that administer those Medicare Advantage plans. And so when something is covered in Medicare B or Part D doesn't necessarily mean it's immediately covered on Medicare Advantage. And so that's a different process that a patient might need to navigate in order to get a new drug or a new device or a new pharmaceutical. Transplant is a little bit more less complicated. Transplant uses what's called a retrospective payment system, where transplant centers figure out how much it costs them to do a given thing, whether that's the initial workup or whether that's the transplant surgery itself for some period of time after the transplant. And then based on their costs, they get some reimbursement based on that. And so I would actually say that the ability to get new and innovative therapies into transplant is actually easiest of all the three categories we're going to talk about: CKD, transplant, and end-stage renal disease, for that very reason. And I think as patients, the support for innovation, coverage, and reimbursement policy is critically important. Coverage meaning, will this be something that a payer will pay for? And reimbursement essentially meaning, how much will they pay for it? And I have here the logo for CMS, which is the largest payer, and we'll talk about them pretty commonly, because as the largest payer for end-stage renal disease, they pretty much set the precedent for what is paid for in dialysis, and private payers and other plans generally follow their lead. So let's talk about end-stage renal disease specifically. The first program I want to talk about is something called TDAPA. TDAPA stands for the Transitional Drug Add-on Payment Adjuster. What is that? Why does it even matter? When the original end-stage renal disease bundle was created in 2009, a certain amount of services were included in that. So what it took to do the dialysis session, a certain number of new medications that were present in 2009, a certain number of labs, and a certain number of devices. Well, clearly the world has evolved, right? If we were thinking about what we were walking around with in 2009, we'd all be walking around maybe with Palm Pilots, and we wouldn't even have heard of cell phones, right? It would have been a completely different time, but technology has evolved. And so TDAPA is a mechanism that allows new drugs to come into the bundled reimbursement system, and CMS will then pay for it for a certain amount of time. So essentially the way it works, it's a very transparent process actually with CMS. If a new drug is approved by the FDA and is one of very specific types of new drugs, then it can qualify for TDAPA. And so the manufacturer would get the drug approved by the FDA, would go to CMS and get a reimbursement code, and then armed with these two things would go to a very specific office at CMS and say, we'd like to qualify for TDAPA. And if those two criteria are met, the FDA approval with a specific type and the payment code, then TDAPA is generally granted. And what TDAPA means is that there is a 2-year period for which this new drug is paid for outside of the bundle. And CMS has done this to encourage providers to be able to access new drugs and determine whether or not they're useful or not useful. And at the end of this 2-year period, in most cases, that money is withdrawn, and then you're back to whatever the base rate was for payment. Now, in certain cases, this is not really sustainable. And as I talk about the evolution of this policy, this post-TDAPA policy is really required for sustainable innovation. So if we take an example that is relevant today, and we look at the drug Korsuva, Korsuva is a medication that may hold great benefit for patients with uricaritis or itching due to kidney disease for some patients. However, the amount of money that was originally put in the bundle in 2009 only really covered oral Benadryl, so a very small amount of money that was in there. And so if we were to use this new medication that actually is expensive, or at least costs more than Benadryl, and there was no incremental reimbursement after the TDAPA period, that would be a big problem. And so there is a conversation going on. CMS actually had a request for information over the summer to say, well, what should we do with post-TDAPA? Is there certain drugs that should get more money back in the bundle? Because obviously oral Benadryl isn't going to cover the cost of Korsuva. And then how should we think about that? So that's the debate that's currently going on. The second issue that I want to just cover briefly also goes back to Medicare Advantage. And this is this important aspect of coverage parity with Medicare Advantage and with traditional Medicare fee-for-service. So traditional Medicare fee-for-service is referred to as Medicare Part B, and Medicare Advantage is referred to as Medicare Part C. And right now there is no equal mandate for someone who is in Medicare Advantage to have the same innovative drugs covered in TDAPA And so that's a conversation that's currently going on. How do we ensure that if a Medicare Part B patient has access to a new drug through TDAPA, that also translates through to the providers that are administering the plans for Medicare Part C, and so that the dialysis unit in this case can not have to worry about insurance coverage between fee-for-service and Medicare Advantage. The second aspect of innovation in end-stage renal disease that I'd like to cover is actually is what's called TPONIs. And TPONIs is a version of getting new devices into the ESRD bundle payment system. So I spoke to you about new drugs, the new devices category, because in dialysis we use a lot of devices, whether it's home hemodialysis equipment or in-center hemodialysis equipment, remote monitoring or home technology. It's a lot of devices involved. And so this is a system that is similar but different than TDAPA. So one, the product has to be approved by the FDA. That's generally the case. But CMS and then the manufacturer can apply for this TPONIs coverage. But the manufacturer has to essentially prove that the product that's being used, the device that's being used, is substantially better than something else. It must demonstrate what's called SCI, substantial clinical improvement. And today, that process with CMS is not as clear as I think the TDAPA policy is. So they operationalize what's called coverage with evidence determination, which is they'll allow a 2-year period for new technologies to be covered, but the approval of that, whether or not it's guaranteed this new money or not this new money, is not clear. So the endpoints are not really well clarified beforehand, versus the TDAPA policy, it's basically if the FDA approves it, they'll cover it. In this case, it's a subjective decision by CMS based on the evidence that's supported and given to them as to whether or not they will cover this or not. And so one evolution of this process could be to increase the transparency of this process, to essentially advocate for what I'll call peri-FDA submission review with CMS to clarify what is required. Now, let me just break that down for you. Essentially, what we're saying is, at the same time the manufacturer of a device goes to the FDA and says, look, I want to get this device approved. Can you tell me what I have to do that? They could go to CMS at the same time and say, look, I'm trying to get this device approved. Here's what my clinical trial will show. If I show these things, will you give me payment under TPONIs? That parallel review, I think, will be quite important. It would give the manufacturers confidence that they should come into the renal space. It'll reduce the uncertainty for a lot of different things, and I think it could be a meaningful improvement. There are examples of this parallel review where CMS and FDA are reviewing things in parallel rather than in sequence in other areas of healthcare, so that could be quite interesting. And again, here, the same issue that we talked about before on TDAPA with Medicare Advantage should be highlighted, which is that we would like to see innovation parity between Medicare Part B, which is regular fee-for-service, and Medicare Part C, which is Medicare Advantage. And so that if TPONIs is granted in Medicare fee-for-service, that we also get that same coverage benefit with reasonable reimbursement on Medicare Part C, Medicare Advantage, such that, again, at the dialysis clinic level, we don't have to decide between who has access and who doesn't, because they're all covered by Medicare. Again, the call to action here for patients is, I think, exactly the same, which is to support both innovation coverage and reimbursement policy. I'd like to cover 2 more topics with you, and this is something that we the community introduced and talked about just over this last summer. And this is what I'll call TLAPA. And yes, it sounds like a fish, but what I would say this is the Transitional Lab Add-on Payment Adjuster. So you might recall that the reason for TDAPA and the reason for TPONIs was that when we created the bundle payment system in 2009, we kind of froze time and said that's all that's going to happen. Well, there's a lot of diagnostics that are required in kidney disease, right? A lot of kidney disease is measured and monitored by laboratory tests. And so we think that there is great potential for new innovation to come into the bundle related to laboratory diagnostic testing. And there are some good examples from outside the US. There's tests that measure vascular access classification. There's tests that measure residual renal function that are used in countries outside of the US that have no clear mechanism for reimbursement within the United States. And so we suggested this year as a community that there's no clear path for new laboratory innovations, and we could potentially think about something that would allow new labs and diagnostics to come into the end-stage renal disease bundle, just as we've talked about drugs and devices. It could follow either one of those processes. The TDAPA process, which is just FDA approval. It could follow the TPONIs process. which is FDA approval plus a subjective assessment by CMS around substantial clinical improvement. I think we might all think that the TDAPA policy might be the right answer of thinking about it. And again, similar to those two policies, we might need to think not just about a small period of time in which this is covered, but how we continue to add money back into the bundle to make sure that patients have access to these innovative therapies even after an initial 2-year period. And then just to be a little provocative and future-reaching, I think there are some new things that are coming down the pike that really could benefit from some thinking around coverage and reimbursement policy. So wearables, for example, there are some great companies that are thinking about peritoneal dialysis wearables or hemodialysis wearables where the dialysis is done almost constantly. You wear a belt or a device and your dialysis is done as you walk around, which would be a great convenience and a great benefit for many patients. How should those be paid for? Some argue those should be paid for as a home modality, no different than ambulatory peritoneal dialysis. Some argue they might need to be put into a completely different payment system. I think time will tell, but it's important, I think, to start having these conversations and debates as you see these new technologies coming into fruition. Next, we can talk about implantable artificial kidneys. There are some people that are working on mechanical devices to replace kidney function, which would be amazing for patients. No external device, no going to dialysis, just an implanted device that purifies the blood and puts the urine back into the bladder. That would be amazing. Which payment system does that fit into? Is that an end-stage renal disease payment system? Is that a surgical code? So that's an idea just to think about. And then I know you've probably already covered xenotransplantation already, but this idea of solving the organ shortage by increasing the number of organs that could be available from pigs and others. Again, how do we think about how that gets paid for? Is that a different process than how transplant gets paid for today? Do we use the same process? Instead of saying it's a human organ, it's now an artificial organ. So I recognize these are somewhat far-reaching ideas, but I do think that these technologies are on the foreseeable horizon. And so it is important to continue to think about how they could come in. But again, the call to action for you all as patients and patient advocates is really to support this new innovation coverage and reimbursement policy for these new things. We want to ensure that patients with renal disease have access to new and innovative therapies, and that all starts not just with the science, but also the coverage and the reimbursement. So where are we today, if I were to summarize where we are? So there's lots and lots of innovation. I hope I've shown you today that innovation is alive and well, and as patients with renal disease, you should be not pleased because we haven't cured renal disease yet, but you should at least be optimistic that there's lots of people trying to innovate in renal disease. And we've covered the big areas. We've covered chronic kidney disease. We've covered transplant. We've covered end-stage renal disease. There's also a lot of service innovation that's happened. One of the side effects of the pandemic was a lot of more telemedicine applications, remote patient monitoring. So I think there's tons of new things that are coming. But the key thing I want to emphasize to you, if you take one thing home with you, is it is insufficient to just have the science or the technology or the product. You also have to figure out how to do the implementation science, we'll call that, right? How do you get this from theoretical bench to bedside? How do you make sure that we translate all this technology into something that actually positively improves the lives of patients with renal disease and the providers who've dedicated their lives to take care of them? In a great analogy, I'd say, look, a lot of these technologies are cars, engines. And most of us are not in the market to go buy an engine. We want a full car, right? We want everything that surrounds that engine to do what we need it to do, which is to go from point A to point B. And so the implementation science is really taking all of that great technology in the engine, putting all the pieces around it, and making it a car that actually delivers value. And to do that, as I've mentioned to you today, there are these 4 hurdles that we've talked about. Is it safe and effective? Can it be manufactured appropriately? Is there awareness for people to know how to get it? And most importantly, will someone pay for it? And these 4 hurdles, just like in field and track, need to be overcome in order to get to the end and get to the finish line. So again, the future of innovation to improve the lives of patients with renal disease is bright. I'm really excited about all the different new technologies that are coming, but we do need to continue to improve the access to these innovations with some of the things that I've talked about. And what I would encourage you as patients and patient advocates is to continue to push the envelope, to continue to push providers, to continue to push payers, to continue to push innovators to ensure that you have adequate cars that improve the lives of everything that you do on a daily basis, and thus actually really make a difference for the renal community. Thank you.
Thank you, Dr. Krishnan, and thank you to all of our speakers. We appreciate you sharing your time and expertise with us, and your perspectives on issues that are impacting kidney care.